This presentation is on acute myeloid leukemia treatment updates. And it's not the entire review, but this is a review here that I used or a section from it to do this presentation. So first, some general considerations for treatment. A patient might be considered fit for intensive chemotherapy if they're young and don't have other serious health issues that might get in the way. It's sometimes easier to identify who shouldn't get intensive chemotherapy because of high-risk side effects and even death from the treatment. People over 75 years old are usually not given intensive chemotherapy because there are other less harsh treatments available, especially less intensive chemotherapy. And the FDA has specific criteria like poor liver, kidney, heart, or lung function that define when a patient shouldn't get intensive chemotherapy. And even if a patient is physically fit, they might not be a good candidate for intensive chemotherapy if they have a type of cancer that doesn't respond well to it. Um, and the goal in treating AML is to get rid of most of the cancer cells and then have additional treatment on top of that to keep the cancer from coming back. And the best treatment plan depends on a variety of factors, and it's going to be unique for everyone. But some of the considerations include the patient's overall health, their cancer's genetic features, and whether they've had certain treatments in the past. So intensive care chemotherapy, the standard induction therapy is the 7+3 regimen with daunorubicin and cytarabine. It consists of cytarabine administered continuously for 7 days and daunorubicin given on the first 3 days. And then there's CLAG-M, which includes cladribine, cytarabine, and mitoxantrone with GSF. And then GCLAM, similar to CLAG-G, but may include different dosing or additional agents on top of what was listed. And then IA is a regimen where idarubicin is used instead of daunorubicin in the classic 7+3 regimen. FLAG-ID includes fludarabine, cytarabine, and CSF, and idarubicin. And then iomustine IA combines the alkylating agent lomustine with idarubicin and cytarabine. So higher doses of daunorubicin have been associated with improved survival in some patient groups in some tests, but there's a risk of increased toxicity that comes with the increase in the amount of drugs. And also some new drugs have recently been approved in combination with the 7+3 regimen or as part of alternative regimens. And then targeted therapy. So we have midostaurin, which is a multi-targeted kinase inhibitor that is particularly effective against FLT3 mutations, which are common in AML. It is typically used in combination with the standard chemotherapy, 7+3 regimen, for patients with newly diagnosed FLT3 AML. Adding midostaurin to standard chemotherapy improved overall survival in patients with FLT3 mutations. And then there's GO. GO is an antibody drug conjugate that targets CD33, which is a protein that's commonly expressed in AML cells. And then venetoclax combinations with hypomethylating agents or low-dose cytarabine can be used. Venetoclax is a BCL2 inhibitor that induces apoptosis in AML cells, and it's approved for use in combination with azacitidine and decitabine or low-dose cytarabine for older patients. And going off of that, most of those are used for those that are not fit for intensive therapy. So hypomethylizing agents are used for those that are not fit for intensive therapy and alters the DNA methylation to combat leukemia. Glastabine in combination with low-dose cytarabine is also an option for lower intensity chemotherapy. for those who can't tolerate the standard chemotherapy. Venetoclax combinations are also good for newly diagnosed AML patients ineligible for intensive chemotherapy, and it targets the BCL2 protein. And then IDH inhibitors, which I didn't mention previously, ivosidenib and enasidenib target specific metabolic enzymes in AML with IDH mutations and are used along with HMAs. These therapies aim to provide effective treatment with manageable side effects for patients who require a gentler approach. And then maintenance therapy is another option. So oral azacitidine, this extends the survival in AML patients in remission who can't undergo a transplant, and it's administered in 14-day cycles. Sorafenib is used post-transplant in an FLT3 mutated AML to prolong survival, and is typically continued for up to 2 years. Gilternib has been investigated as a post-transplant maintenance to prevent relapse in the FLT3 mutated AML, and various agents have been studied to reduce relapse risk by targeting residual disease, and maintenance therapy is tailored based on relapse risk, MRD status, treatment tolerance, and the general aim to extend remission while maintaining quality of life. Allo-SCT is a treatment where patients receive donor stem cells to replace diseased bone marrow and aims to eradicate leukemia via establishing healthy blood cell production. And it's considered for patients with intermediate or adverse risk AML in first complete remission, as it offers a chance for long-term remission in AML, especially for high-risk cases. Investigational therapies are new treatments under clinical evaluation for AML. They include targeted therapies for specific mutations, immunotherapies to boost the immune response, epigenetic modifiers, and novel drug combination. Clinical trials test these therapies' safety and effectiveness across multiple phases. Recent advances show promise in therapies like bispecific T-cell engagers and small molecule inhibitors, and patients may access these therapies through clinical trials. Considering the potential risks and benefits, these therapies are at the forefront of AML research, so they offer potential new options for treatment, resistance, or relapse cases, especially since there is no definitive treatment right now. Yeah, that's all. Thank you.